Our faculty for today is Dr. Asif Iqbal. He is the Senior Consultant in Respiratory Critical Care Medicine in Apollo Multispeciality Hospital, Kolkata. And his area of interests are respiratory critical care and ECMO services.
Listen, this will not be a directive lecture. ABG interpretation is always you need to participate. Otherwise, it is a very boring subject. Okay. So I will request everyone to have the page and paper. Before we go, I will not go in details of all these things. What is needed in the EDIC or IDCCCM? It is important that you have to know the normal value, and by reading the cases, you have to understand the actually what case you are dealing and what will be the diagnosis by seeing the ABG. Okay. In your EDIC exam or in your IDCCM exam, nobody will give you to calculate the anion gap or these things. But from the question stem, you have to calculate your anion gap, osmolar gap, and you have to interpret the what exact cause for these things. So ABG is very basic to know. Every doctor, not only the critical care physician, the physician and the after MBBS, you have to know the ABG. It is a very basic investigation in ICU. I'm audible to everyone.
Yes, sir.
Yeah. Okay. So for the pH is normal value is 7.35 to 7.45. But when you are calculating something, so you will calculate, it take the pH value is 7.40 for the calculation. Similarly, when you are calculating of carbon dioxide, PaCO2 will be 40. In case of bicarbonate, 22 to 24. And for the calculation, it is 24. And PaO2, though it is written in the 90 mmHg is the normal, but it is a 100 is the normal. PaO2 FiO2 ratio, though it is not the directly part of your ABG calculation, but you must know when you are seeing the patient in a ventilator, and the you have to do the PaO2 FiO2 ratio to understand the lung pathology. Similarly, PaO2 calculation, the alveolar oxygen concentration, that is your FiO2 into atmospheric pressure minus 47 by PaCO2 by the respiratory coefficient is 0.8. And A gradient, there are certain gap you have to understand, that is the gap, the PaO2 and PaO2 gap, and also the EtCO2 gap. So we will discuss later on. And when you are dealing with the ABG, your ABG machine have to supply the certain electrolytes like sodium, potassium, chloride, chloride, and also sometimes calcium. And this is the basic thing to calculate the anion gap. So first rule is in acid-base abnormality, when you are seeing the ABG, you have to understand that what basic problem, what is the pH, whether it is in the normal range or is it acidotic or alkalotic. The rule number 2 is if PaO2 and the pH are abnormal, then you have to see the direction of change. If both are same direction, then it is a primary disorder is metabolic. If pH and PaCO2 in opposite direction, then it is primarily respiratory. So there are two types of metabolic and two type of respiratory acid-base disorder. One is metabolic acidosis or alkalosis. In respiratory acidosis and alkalosis. Regarding the respiratory acidosis, alkalosis, you have to diagnose whether it is a acute or chronic, or it is a acute on chronic. So I deal my respiratory ICU where the most of the COPD patient coming with a acute and chronic problem. So you have to see the bicarbonate level and the PaCO2 level. So you will understand whether it is a acute and chronic, or it is a chronic problem, or in the acute problem. Now, ABG interpretation rule number 3 is either your pH or PaCO2 is abnormal, then it is a mixed metabolic or respiratory disorder. So in a simple, there are multiple literature on the ABG, multiple book on the ABG. I have made, this is my, you can say it is my note. I have made it very simple that if the pH or PaCO2, any of one is abnormal, then suppose pH is normal, but your PaCO2 is abnormal. So it is not a simple disease. It is a mixed disease, mixed metabolic and the respiratory. Excuse me, host, please mute.
Yeah, it has been done. Thank you.
So if pH is normal, then direction of change of PaCO2 indicate the respiratory disorder. If PaCO2 is normal, then direction of the pH change is identify the metabolic disorder. So in the rule number 2, we have seen that pH and PaCO2, if both are changing, so direction of the change will give you diagnosis of metabolic or respiratory. Here in the rule number 3, if the any of one is normal and other is changing, so what is changing? That is the primary disorder. So either pH or in the PaCO2. Now coming to the rule number 4. Rule number 4 is the primary metabolic acidosis or alkalosis. Find the expected PaCO2. That is the compensation. Whether it is a fully compensation or it is something overcorrected. So now in the chronic respiratory acidosis, the expected pH will be 7.4 minus 0.003 into PaCO2 minus 40. In chronic respiratory alkalosis, it is 7.4 plus 0.003 into 40 minus PaCO2. So here, to make it simple, for respiratory acidosis, acute or chronic, the calculation will be in acute 7.4, 0.008. In also in the acute respiratory alkalosis, 7.4 plus 0.008 is the coefficient unit. And in chronic cases, it will be 0.003, both in chronic acidosis or alkalosis. Now next slide. So example, pH is 7.66. So it is it is acidosis or alkalosis. Anyone please volunteer?
It is alkalosis.
Alkalosis, very good. So PaCO2 is 23. So you apply the rule. So it is
Respiratory alkalosis.
no, it is in the opposite direction. So opposite direction. So primary disorder is respiratory alkalosis. Now, rule number 3 is respiratory alkalosis. Now, you have to check the pH, expected pH changes. Okay. So pH will be 7.4 plus 7.536. So expected pH will be 7.536. But here you see the pH is 7.66. So means something, so it is normal. So PA gradient. So oxygenation, PaO2, SaO2 are both reduced in the room air since PaO2 elevated, PA gradient is elevated and low PaO2 can attribute it to VQ imbalance. So there is a pulmonary problem and SaO2 is reduced in the part of low PaO2. Regarding your ventilation, adequate patient level of carbon dioxide production and the patient is neither hyper or not hypoventilating. So PaCO2 is 37 means adequate. Acha. Then your acid base, coming to acid base picture. So rule number 3, PaCO2 is normal, then directed change of PAH will indicate the metabolic disorder. So it is a metabolic alkalosis. And rule number 4, what is rule number 4? The expected PaCO2. The expected PaCO2 rule number 4 mein kya tha? If it is a metabolic alkalosis, then 0.7 into PaCO2, 0.7 into bicarbonate plus 21 plus minus 2. So expected is 43, but PaCO2 is 37. So here metabolic alkalosis superimpose respiratory alkalosis. Now case number 2. 46-year-old man has been in the hospital 2 days with a pneumonia. He was recovering but has just become diaphoretic, dyspneic and hypotensive. He is breathing oxygen through nasal cannula 5 liters per minute. The ABG showing pH is 7.4, PaCO2 is 20, PaO2 is 80, SaO2 is 95%, bicarbonate is 13.3 gram. Sorry, hemoglobin is 13.3 gram, bicarbonate is 12 milliequivalent. So how would you characterize his state of oxygenation, ventilation and acid base balance? So tell me anyone about the oxygenation. PaO2 is 80. On nasal cannula 5 liter. So nasal cannula 5 liter means how much is the FiO2? Anyone? Please volunteer.
Yeah, it's around 40%.
Around 40%. Yes. So 1 liter equal to 0.4. So 5 liter is 0.4 into 5 is 0.20. And the normally is normal here is 0.21. So it's 0.4 FiO2 or 40% FiO2. That's absolutely correct. So regarding the ventilation status is okay. So if expected bicarbonate, expected PaCO2.
Yes, sir. The 55.3, sir.
Yeah. So expected PaCO2 is 55, but here observed CO2 raise is 67. So it is
Yes.
more than your expected PaCO2. So there is a secondary respiratory acidosis is there.
Yes, sir.
Okay.
Yes.
So in case of metabolic alkalosis, you have to remember, you have to measure the urinary chlorine. Okay. Why it is important? Chloride, urinary chlorine. So what is the commonest cause of metabolic alkalosis?
Sir,
Bolo.
what? Sir, repeat the question, sir. What is the?
Is in metabolic alkalosis, is there any role to measure urinary chloride?
Yes, the chloride responsive and unresponsive.
Yes, very good. So chloride responsive or unresponsive. So if urinary chloride level कितना होना चाहिए?
Sir, 20 might for around 20.
Yeah. So the whether this chloride responsive metabolic acidosis or not, to know, you have to measure the urinary chloride. If it is more than 20, then it is non-responsive. It is less than 20, it is responsive. And the range, sometimes some books says that 25 or 30, but remember, if more than 25 or 30, then it is a non-responsive. Okay. So what is the probable etiology of above ABG drainagement? Because of COPD, it is a chronic COPD. That's why.
Yes, sir.
Okay. And one thing I have not mentioned in the ABG, you will not get only the ABG. Usually in EDIC exam, there is a two. In part one, you have to diagnose by calculating the ABG and all the values to identify the what disease is going on. In part two, you will get question in a step. Like one diver is not diver, it is a garage when a question will come like that. One garage mechanics found unconsciousness in the garage. Then he has been shifted to hospital, and on evaluation GCS it's around 10, and patient doing the gasping breathing and showing ABG value is like that, and glucose, urea, burn. So in that question, you have to do the ABG calculation, anion gap, along with osmolality gap. Okay, so you have to, if there is a given you the glucose value, if they will give you the your burn value, then you will think about that they are asking question on the ethylene glycol poisoning. And the history is showing that garage mechanics is like that. So it is easy to access them for the ethylene glycol. So you have to measure the osmolality gap also. If high osmolality gap, then it is a salicylate poisoning, or it is more common in the ethylene or methanol poisoning. Okay. So by understanding, by reading the stem, you have to think about the what direction of question is coming, because it is the EDIC part 1 and part 2 all about the ball game of time management. That's why this calculation you have to be you have to remember, mug up the all rules for the ABG calculation, and it should not take more than 30 seconds to 1 minute to calculate the value. Okay. So that's all about my ABG classes today.
Thank you, Dr. Iqbal.